I really appreciate everybody who came in attendance for our annual CV Heart Team meeting. We've been doing this at our hospital, here at CVI since 2016. So I think this is actually our 9th annual. Really want to thank the board of directors at CVI for giving us a platform to share and gain knowledge from. And I've got a distinguished panel, which we will introduce. But first off, I'm going to kick it over to Liz Perpetua, who's going to join us via Seattle virtually, just to give us a little bit of an intro into the context and historical background of our meetings. So Liz, it's all yours.
Well, good evening. Can you hear me okay?
Yes.
Okay, wonderful. And you can see my slides okay?
Perfect. Thanks, Liz.
Wonderful. Well, thank you so much, Marcus. I am just so thrilled to have the opportunity. Thank you for making this possible for me to present from Seattle. I have been very fortunate to take part in CVI since its beginnings, and I'd love to just share a little bit about who we are is how we lead, and this parallel journey of myself as a CV team member and CVI. So it will be a bit of a whirlwind tour, and Marcus, it's also a love letter to CVI, as well as what you have built and what the leadership has built, committing to peer-to-peer education for the heart team. So first, I just want to share for everybody in the room, who we are matters. What we do matters, and my joy is to honor this simple truth. I love to see the unwitnessed, invisible work of the CV team become witnessed and visible. I love to create patient-centered innovation and care delivery to match innovation in technology. And my passion is to share who we are and what we do in community through education, mentorship, research, and dissemination, especially through presenting like we are today and through publication. Evidence-based practice starts with your why, your passion, and your purpose. So for me, as a Filipina first generation, Filipina American, you've never met a Filipina nurse, I'm sure. It's been about family. It's been about being, at these different tables, whether that's been the cath lab table or, the panel that you're at now, in the seats that you're in now as attendees, and then being a mom. And that's been so critical for me at this center where policy, guidelines, professional societies, and of course our patients are at this center and intersecting, where there's opportunity for us to really find our joy and to be able to show how innovation begets innovation. And I've been very fortunate to be a part of this work since 2008, since the first transcatheter valve therapies courses, and also CVI, to be able to, with live cases, with research and so on, work with people like Dr. Burns, with the, Abbott Northwest, the Minneapolis Heart Institute communities, to understand what these clinical pathways are. And so moving these clinical pathways into understanding what is it that nurses and techs and APPs are doing to actually change outcomes, to actually make a financial impact that is based on just what we do every day to reduce things like length of stay and to impact care. And this was one of the first, examples of me doing this for transfemoral and alternate access TAVR way back in the fiscal year of 2014, where we showed that we saved almost, $750,000 in 6 months just by doing what nurses and techs and APPs do every day. And so I really want to encourage you to not ask what the world needs, but to ask what makes you come alive, and to go and do that, because what the world needs is what makes you come alive. And at that point in time, really, my life changed entirely. I became a single mom. I had to think about what made me come alive. There were all of these different things that were happening in education and in research and in conferences. And what came up was, for me, this totally, blue sky possibility of what if patient-centered team-based care was always optimal? And, from that, what if it's our voices, our very own voices, our very own data that are actually defining what we do? just like at CVI, where you are now. It's a platform where you're sharing, you're hearing from your peers what their best practices are and what they're doing, defined and articulated in our own words. So that's what inspired me in 2017 and my co-collaborators to present this poster in ACC scientific sessions in Washington, D.C., and just being able to describe what are advanced practice nurses doing and what is this landscape of heart team coordination. You know, we've now had this 7+ year cycle of CVI. And at this very sort of dark and light time in my life, I received this invitation to present and to serve as faculty alongside Dr. Marcus Burns for CVI. And it really was so inspiring to me to think that, yes, you know, here we are in 2018, we are going to share what we're doing in our organizations. We're not going to do this in silos. We're going to talk about the work we do. We're going to talk about who we are, and we're going to make it known. And it was very much, you know, something that was still novel. I think it's even still novel today to attend symposia with content that is germane to our work. So here we are then in 2019, being able to expand the faculty, being able to expand, you know, the type of content that's being delivered. And the important thing is it's truly the science, it's the evidence, it's the quality improvement, it's the process improvement. And that's what, you know, Dr. Burns, what the CVI leadership were really trying to showcase for structural heart team professionals. And that poster that we presented in 2017 culminated ultimately in a paper that was published in Structural Heart Journal. And if you haven't had the opportunity to look at some of this, even though it's from way back in 2017, you know, here we are with TAVR, we've got TEER, both for mitral and tricuspid, and we've got TTVR with tricuspid valve replacement, and then all of these other, you know, therapies now, including TMVR with Tendyne that's FDA approved, as well as what's in clinical trials. So all of these things we've continued to build upon. And for me, I just even wanted to build my replacement. So I was looking early on, and maybe some of you will be talking about this and thinking about this today, about how can we automate all this application of evidence-based practice, leveraging the EHR, using rules engines, even using AI platforms to help us do that. And while I built software, not as a software developer, but guiding, you know, software teams, and ultimately it wasn't something that was, you know, in this pocket very successful, I learned from it. And in those learnings, I continued to be able to do things like serve as an editor for Structural Heart Journal, be recognized around breaking glass ceilings for structural heart disease, publishing textbooks and bringing communities of people like us together to be able to even edit the textbook from which I learned how to be a cardiac nurse way back in my baby RN days. And so now, you know, we're at this cusp of having a brand new national coverage determination kind of, you know, review for TAVR. Back in 2019, that review led us to having some new changes and reducing the number of cardiac surgeons that needed to see patients from 2 to 1. And we are also in this place where a tremendous amount of data has been released and needs to be incorporated into a new guideline. But back in 2019, we were talking about this from the nursing and allied health perspective, and your voices are needed now more than ever. And throughout this kind of gap period where CVI, you know, in 2019, we had COVID then in 2020. So there wasn't a CVI in 2020 or 2021. So what were we doing to be able to disseminate this information? We were writing other papers to talk about optimizing processes of care. We were, you know, putting on videos to be able to share this type of information. And we were relying upon professional societies to really recognize the work of the CV team in ways that allowed us to be seen as real partners. And that meant even designating, you know, people who had met certain, you know, career characteristics and contributions as fellows of the American College of Cardiology. And that was not necessarily welcome, right, by all. And with any type of change, right, some people don't appreciate that, calling it a revenue pipeline, saying, you know, is this actually credible? And the ACC being a professional home, being able to support us us in these processes and allowing us in our communities, standing on the shoulders of giants like Dr. Gigi Wyman and others, to just celebrate our successes. So here we are then in 2022, where finally, after a 3-year gap almost, post-COVID, we're coming together to talk about what the heck did we do to take care of patients during that time? What were our innovations? And, we continue to build upon this in the platform that is our specialty. And for the first time, we had been able to actually incorporate the coordinator as well as the APP at all levels of the multidisciplinary heart team in cardiovascular medicine in this expert panel paper that was published in JACC Advances, where really the patient's at the center, but for the first time, the coordinator and APP is mentioned in every scenario. And that was a big win for us, and something that you're continuing to do and talk about as you're at CVI today. There's a specific implementation science initiative that American Heart Association also launched that year in 2022, which is target aortic stenosis. Some of your faculty there today are part of this initiative, where we're using that same idea of a door to balloon time of 90 minutes to actually consider getting to a door, meaning diagnosis by echo of a class 1 indication of aortic stenosis needing treatment, to treatment within 90 days. So many of your, faculty today are part of this initiative in their hospitals, and a number of us who are on the scientific advisory group are trying to, work with your programs to make this possible. And, I used to geek out and listen to these people on podiums and read their publications, and now having the opportunity to, sit along and stand alongside them as we lead this care, and doing that actually at the boots on ground level still too, just like everybody here, where I've continued to just reduce the number of encounters and the number of times patients have to come in for treatment, really trying to make that, one-stop shop situation possible, reducing those wait times from, things that are over 60 days to really moving to 40 days and 30 days, and then being able to ensure that sites are also collecting the data that are needed for public reporting, and that TVT registry public reporting eligibility is possible because the data collection of patient outcomes and patient reported quality of life is actually part of that process. So that brings us then to CVI 2023, where you can see how much larger our faculty became. There's Dr. Burns and myself alongside just total OGs, total stars in the, space, just continuing to share what we know. And for the first time, we also had the opportunity to share an example of a CVT member being a first author and a chair of an expert panel for JACC. And this was published in JACC Advances on Shared Decision-Making in Cardiovascular Care. So that's actually what I presented on in CVI of 2024. So there's many other initiatives that are available in your programs that I've worked on. Readmission is one of those, just being able to show how can we reduce readmission rates, what's that estimated economic impact. I'm going to be actually presenting this at ACC's Quality Summit, and that's going to happen in October of this year. I'll present live a nurse practitioner and nurse-led multidisciplinary heart valve team intervention, decreasing 30-day readmission rates after TAVR. And so much of this rich wisdom has come from being able to learn from this community, making friends with people that are on the panel, that are on the podium, and that are in the audience. So most of the people that are next to you now have the answers to your questions, and you've probably solved some of their problems already. So please share. Where am I now? I am actually co-investigator of a study called the Heart Valve Team Evolve Study, because the heart team is a class of recommendation 1, level of evidence C, which means we don't have any evidence, it's more eminence. It's that level of an intervention. And so as we try to understand this phenomenon better, as now we anticipate a review of the TAVR NCD, The valve guidelines are in review to be published for an update likely in early 2026. I'm working with the Heart Valve Collaboratory and a number of other investigators to study the heart team. And so our aim is to be able to publish and present this in the next 6 months, just in time for all of these very exciting changes that are happening in the field. And you can see this presentation looks really like almost like a yearbook, because it's the people that make these changes. It's the people that make these processes possible. And that's what patients really need. So that brings us to 2025. Thank you so much, all of you, for being here. You've got a phenomenal faculty here with you today. You've got Natalie Kelly from Christus out of Tyler, Texas. You've got Sarah Kennedy out of Centera in Norfolk, Virginia. You have Dr. Courtney McAlister out of UT, out in Houston. And you've got Caitlin Reen, who's coming from Mass General, as well as Misty Theriot from Lake Charles Memorial in Louisiana. And of course, my co-chair, Dr. Marcus Burns, who I've been very, very fortunate to present with over the past 7-8 years in this space. That brings us to the beginning. And I don't know that we ever get comfortable talking about ourselves and sharing our stories. I hope you will do it anyway. Never doubt that a small group of committed, thoughtful people can change the world. Indeed, it's the only thing that ever has. Thank you, Dr. Burns, and I will now kick it over to you for the beginning of the CVI Heart Team Symposium. Thank you so much for your attention.
Thanks, Liz. A lot of applause going on here. It was an incredible homage just to the history, and I will never forget meeting you and other individuals when I started my career in 2015, and I was shaking in my shoes. Trust me, like you say, you guys are the OGs, you guys are the giants, but you guys took me under your wings and taught me so many lessons and really set the stage for a beautiful future for us all. So thank you so much for the knowledge and your gift that you've provided me and so many hundreds and or thousands others. So thank you, Liz. Thank you for coming in today.
Thank you so much, all of you rock stars in the audience on the panel. Thank you.
Thank you, Liz. Thank you. So we're going to keep the program going here. I'm a little bit of flipping the script here. I'm going to change the tune. Many of the talks were kind of geared towards TAVR, and we had one attendee that just wasn't able to come as far as the faculty goes. So I'm going to tip it off here by talking a little bit about the AV valves and tricuspid valves and taming the tidal waves. So I'll move forward here. These are just my disclosures. So again, really an honor to be here today with this distinguished panel. I just think it's really important that we recognize the incredible work that we all do, this distinguished panel of speakers, but that also goes to include every single one of you guys and attendees in the audience. Your dedication and your contributions don't always receive the recognition that they deserve, but make no mistake, I think that advanced practice providers, registered nurses, CVTs, RTs, program coordinators, and all the members of the Greater Heart Team, we are really the backbone of the care delivery that's given to the structural heart community. And really, we are the ones that really deliver the care for the predominance of the patients that we see. So I truly believe that the work that we do elevates both the quality and consistency of patient care. And so I just don't want you to lose sight of that, and the importance of the contributions that we provide and the impact really speaks for itself. So it's really, really great. ICs really get a lot of the flash, trust me, we can't put their work aside, but the patient just doesn't end up on the table, right? So, again, the workload that we put in really is behind the scenes, and I just really want to elevate this role and make sure that everybody recognizes that. So digging into the topic. So when we think about TR, it's often been described that it's a forgotten valve, and literally there are so many reasons why it's been neglected. We could probably list about 100 of these here today, but what I want to bring forth is 3 common themes, and I'll ask you to consider these 3 themes tonight. First, TR patients are often survivors of other cardiovascular diseases. Think about when you're in clinic or in hospital service and you're seeing these patients. It's common that we discover this either after or during the evaluation of left-sided mitral aortic valve disease, and in these patients who are at elevated risk for surgery. So it's either that or tricuspid regurgitation is discovered in the setting of chronic HFpEF symptoms, and sadly, it becomes kind of this afterthought, right? As a result, it completely flies under the radar, and it's this long, indolent process in which, in the interim, you can manage the disease by using diuretics or guideline-directed medical therapies, but I think ultimately what we've learned is the right ventricular function is a late prostattic indicator, and let's just say it really is good until it isn't. I mean, you think about the LV function, and when you have poor LV function, it's not a good scenario, and the same thing is for the right ventricle, and we need to respect the right ventricle. So we also know that the severity of TR is easily underestimated. When you just look at color, it's going to look relatively unimpressive, but when we compare it to the left side, and that's because the right-sided pressures and the momentum is much less than it is on the left. Looking at the guidelines, I think simply the neglect of TR and the science behind TR has actually led to a complete paucity of indications as to when and how to treat tricuspid regurgitation. When we look at the valve guidelines, especially in the United States, there's only a single Class 1 indication for TR intervention, and that's when TR is severe and a patient is undergoing left-sided cardiac surgery. All the other indications are Class 2A or 2B. And for isolated TR, again, there is no Class 1 indication. Furthermore, the level of evidence is a C. In other words, it's pretty much a bunch of anecdotes. And so in summary, we still do not have a good consensus as to when and how to treat these patients. But I'm hopeful with the upcoming revised guidelines that we will make changes to this. So looking at some natural history studies, and this one is a little bit outdated, but I think it tells a good story. When you look at these patients, they do quite poorly, and that's because of that neglect and lack of science and understanding and how and when to intervene. This was a study that was conducted at Mayo Clinic, and again, it's a few years old, but clearly it demonstrated that the 10-year survival in a community population of tricuspid regurgitation patients is about 14%. That's absolutely abysmal. Essentially, 90% of these patients suffered mortality within 10 years, and it doesn't even matter if the TR is in the context of other etiologies or if it's isolated. These patients do exceptionally poor. A mere 10 years ago, transcatheter-based therapy options for patients were essentially non-existent. However, today, we have witnessed an emergence of innovative devices and designs for both the repair and replacement that have significantly advanced our treatment capabilities. So we're going to dive into that a little bit. So I'm going to take you a little bit back in time. My career started in 2015 in my current role, and this was back in 2016. This was an 82-year-old female. Are the slides advancing? Because they're not up here. You can go forward. Keep going. Great, thank you. This is an 82-year-old female. She had torrentially severe tricuspid regurgitation. She had a prior TAVR operation and multiple comorbidities that placed her at high risk for surgery. She had 2 heart failure hospitalizations in the past 6 months, and she had class 3 to 4 symptoms that were refractory to escalating diuretics. As you can see, her tricuspid regurgitation is quite torrential, and the slide on the right shows, again, that the gaps were quite big, around a centimeter or so. Her right atrial pressure was 18 millimeters of mercury, and she really had no options. So back in 2016, we had really only the M-tier system available to us. So we untook this case, but unfortunately, this was unsuccessful in our endeavors. And some of which was derived by that we were using an off-label M-tier system, which the steering sleeve was subacute, and you can compare that to the tricuspid tier system, which is now available on label with the appropriate curve flex. And really, it makes a huge difference as far as success goes with these therapies. Abbott loaned me this slide, and I think it gives a good view, a high-level overview of the concept from our clinic all the way to beyond. Early reports with tricuspid tier therapy was back in 2015, and there were some anecdotal reports beyond that in some of the major conferences, but design and refinement led to the actual EFS trial being conducted in 2017. We were fortunate to be a part of the team that performed the first tricuspid tier in the nation. And again, this set the precedent for continued success, IDE trial, development of the device, the G4 system, and ultimately CE mark, which occurred back in 2024. So this was another great shot, and I will cause your attention to the fact that you don't see me in any of these slides, and that's the fact that I was probably behind the scenes doing what we do best as the heart team and taking care of the patient and or doing the scud work, as they say. So looking at our volumes at MHI, putting the lens on us a little bit, just shows kind of some of the exceptional growth that we've seen over the course of time. Again, that patient that I described back in 2016 was one of very few patients that underwent a off-label therapy at that point in time. But as we had the trial enactment, our volumes continued to grow. And you can see alongside of that, paralleling that, is our referral for isolated TR patients has continued to exceptionally grow over the course of time. With the commercial approval in 2024, we performed 89 cases, and to date, this is our number and counting, which just again shows some incredible growth over the course of time. I had the fortunate to work with Gigi Wyman on a publication that we put out in a manuscript about tricuspid regurgitation and the heart team. We all know the origins of the heart team dating back a number of years, which was kind of a small, refined heart team. But what we can see in the blue and the red is just the extension of that with the multidisciplinary management of tricuspid regurgitation. So you have multiple other avenues that are involved in these patients, not only APPs, coordinators, research team, heart failure specialists. If you have pacemaker leads, you may be talking about EP doctors, so on and so forth. So a huge extension. So as far as a key pearl goes, the complex care coordinations that's associated with these patients is huge. Alongside of that, I think that you really need to get familiar as far as prior authorization with these patients. Medicare Advantage still really doesn't recognize some of the commercial approvals, so I would ask you to lean on your industry personnel and or your business office personnel to help with this process because it can be quite intense and laborsome. Prehab and optimization for these patients can be exceptionally critical. So, looking at doing your pre-op prior to therapies, days and or weeks in advance, looking at doing a right heart cath up front, and considering an admission for these patients for optimization. Oftentimes we see these patients as new consults in the hospital, and I've never met an emergent TriClip, so I think that having the patient convalesce home, plugging them in with your advanced heart failure specialists, and garnering their expertise as far as guideline-directed therapies is really, really big. And we get so used to the days of 24-hour admissions with our TAVR patients, and this is really, really nice, but it's not always achievable with this subset. So I think you have to really think about optimizing these patients prior to discharging them if you're looking for success within your program. Really quickly, I think some of the 5 big successes as far as imaging goes, looking at gap widths. You really want to look at that distance that you're trying to grasp these leaflets, because some of these are just unachievable. You have other numerous things like pacemaker leads, horizontal hearts that lead to shadowing, depending on what your morphology is, and multiple coaptation planes. And again, not forgetting about the RV function and thinking about what option is best for your patient. Lastly, again, this commercial approval is only a little bit more than a year ago, and so it really shouldn't permit your team to go rogue on these patients. I think there's many centers that have adopted these therapies that are essentially just doing them to do them, but I think we really have to think long and hard about the successes that were built within the clinical trial, thinking about careful patient selection, again, reinforcing guideline-directed medical therapy. I wish I had a nickel for every time we see a patient that's only been on 10 milligrams of Lasix or something like that, right? So let's optimize the patient and make sure the TR is actually severe. And you really have to individualize or tailor the treatment to the right patient. And maybe TEER therapies aren't right for them and you need to explore other options. So bringing you back to the case scenario, this is the same now 89-year-old patient. She survived over the course of time. She still has torrential TR, and fortunately now we have a TTVR option for this patient. She underwent a successful VDINE TTVR, and she has absolutely no TR, and she's doing amazingly well in clinical follow-up. So I'd like to give a special thanks to my entire team, Dr. Sraja, Dr. Hamid, Dr. Bapit, Dr. Cavalcante, as well as Dr. Vudris, who is not listed here because this is an old slide, but most importantly, my entire team at MHI, and so I welcome any questions that anybody has. So thank you so much. I know I went a little over. Go ahead. Yeah, I mean, I'll just quickly kick it off and then I can hand the mic to these other individuals. But I think a lot of times these are concomitant disease processes. And so I don't know if that's what your experience. And so looking at what sequential therapy and or treatments are available for them, I think oftentimes we see patients with both MR and TR. And usually the preferred modality is that we would treat the MR and then, potentially even close the septum and move back and let them convalesce and then bring them back in 30 days and treat the TR too, so.
I think it's a lot about education too. I think, for those of us that do this every day and are in structural programs, we see this all the time. We know all the guidelines, so we have done a lot of focused education to our referring providers. So we go out and say, these are the new guidelines for aortic, mitral, and tricuspid. I think people hear the new word tricuspid, they get excited, and then it's almost like they're not paying attention as much to the mitral. So I agree. We've seen a little shift in it as well, but we went out and we did some education, which we take on for ourselves as APPs, and I think that's really changed the wave in our group. It's a great question. I've seen it too.
I'll just speak up really quick. I was just going to say, I totally agree. I totally agree with Marcus. I wish I had a penny whenever a patient came in and didn't have good GDMT. But what I really noticed is with the mitral therapy, since we're so far out, a lot of our referrings are really starting to understand GDMT better for the mitral therapy. So as we're getting patients in, one of the reasons that our volume is decreasing is because they're doing a better job managing them, because we've done a better job communicating with them what we need from those patients.
For GDMT in the community too, it's like, well, they're on 20 twice a day, and you're like, oh my God. So, I think that's also education there, and they're coming in better prepared. They're coming in prehabbed because we did a lot of that work up in front. So I think that's.
Any other questions? All right. Oh, how do I go all the way to mine?
If you can move to the next deck. This is Sarah Kennedy.
I can just keep pushing. Okay, there we go.
Perfect. So again, thank you, Sarah, for being here today. She's the lead APP and structural valve coordinator at Centura Hospital in Norfolk, Virginia. And she's going to give us a little bit of a lesson on optimizing the heart team discussion and selecting the right valve for the right patient.
All right, good evening, and thank you, Marcus, and the CVI team for having me. I'll warn you now, I'm not very good at staying still. So if I'm on that side, I'm sorry in advance. And I'm a little shorter than Marcus, so it's a little bit hard to see. And my clicker's not working.
It's not quite advancing.
All right, cool. All right, so my name is Sarah Kennedy. I'm a nurse practitioner. My background is I was a medical ICU nurse and then cardiothoracic surgery ICU nurse, or NP, and then moved over to the cardiology side of structural heart. And I've been doing that for a little over 10 years. This is my team. I'm from Norfolk, Virginia. We have a pretty big program. We do about 500 TAVRs a year, about a little over 100 MitraClip, TriClip, all of the structural procedures. So what I'm going to talk to you about today is optimizing the heart team. And this is really dear and near to my heart because it kind of was created out of a necessity. So we all know the guidelines say that a multidisciplinary heart team assessment and conversation is necessary for TAVR. And now we know with MitraClip and the new NCD with TriClip, also you need to have that heart team discussion. But this also translates to coronary. So CHIP programs are having meetings with cardiac surgery and interventional cardiologists to make decisions regarding high-risk PCI and CABG. And it also translates to vascular. Vascular and cardiac surgeons are having these meetings to decide how they're going to fix that aorta, whether it's going to be a TAVR, whether it's going to be a stepwise approach. So this translates much more than just structural heart. And who is in the heart team? So I've always used this picture on the right of the screen, but I actually like the one Marcus included better that was more comprehensive in the blue. But what I love about it is the patient is always in the center, because no matter what we do, no matter how busy our programs get, we have to remember what this is all about. And beside it, those are the guidelines for a multidisciplinary valve conference from the European Society of Cardiology. And it's all very important, but I've kind of picked out a couple things that I like to focus on. And the first one is the importance of imaging. What I hear when I talk to other coordinators and other programs is that, decisions for valve selection or decisions whether the patient's going to SAVR or SAVR CABG or PCI TAVR are sometimes made, in a room just with the cardiac surgeon and the cardiologist, and then somehow that gets back to the coordinator, the nurse makes the arrangements, calls the patient, and it goes from there. What's missing in that situation? Well, you're missing an imager. You're missing someone pulling up all the imaging, the cath films, and discussing that as a team. Because we all have really busy programs, and we're all human. We're all going to miss things. But if we're all sitting at the table and looking at that data, there's less that we're going to miss. And then we're going to focus on individual anatomical and procedural factors, looking at that access, deciding on alternate access as a team, and then taking into account the values and the expectations of an informed patient. Because think about if you were on that table. What kind of heart team discussion would you expect and would want? I would want everybody at the table looking at every piece of information that they have and making the decisions based on that. So not only is this important for efficiency and compliance, but also for safety. And now, as all of this data continues to evolve, so now we have early TAVR, we're doing TAVR and bicuspid valves, we're doing valve and valve, we're looking at lifetime management, we're incorporating coordinators into every role across the continuum of care. And then now the newest NCD with TriClip, it's more important than ever. So with our specific program at Centura, we have a busy program, and what we would do with our heart team discussion is between TAVRs, we would all sit in a room, go through the case really quick, talk about 5 or 6 patients, go back to the OR, come back, discuss 5 or 6 patients, go back to the OR. And it was just like a hamster wheel, okay? And so we said, how do we fix this? So we decided on a time, 7 a.m. every Monday morning. we're going to review 20 to 25 of our structural heart patients. We're going to go through every piece of data that we have, and we're going to make a decision there. No patient is leaving the room without a decision. And what does that look like? So this is kind of what we created for our heart team discussion. It's basically a one-page outline that has all the pertinent information, and this one is just for aortic stenosis, but we do something similar for mitral, tricuspid, and then some of the complex coronary stuff as well. But this is a one-page slide, and it has really all of the information that you would want when you're making a choice for valve selection for a patient. So it has all of the docs on the top. It has your pertinent past medical history. You have labs. You have your EKG, because if you're a TAVR program, you want to know if that patient's at risk of getting a pacemaker, because that may dictate what kind of valve you're going to use. We're looking at the echo. We've incorporated an advanced imager into our program this year for the first time, and while we're talking about all of this data, that imager is pulling up the echo images and looking, because when I saw the patient in consult, I might have seen moderate MR. But then when we're talking about it as a group, now that patient's had a TEE and it's actually severe. So is TAVR the right therapy for this patient, or are they now at a double valve strategy? We're looking at the roadmap to TAVR, because now more than ever, it's more important when we plan out that patient's first valve, we're also looking to see what the second option is for these younger patients. Are their coronary heights going to be high enough? Are their sinuses going to be large enough? We need to plan all of that out with this first valve. And then true surgical risk. I love this, because when you're looking at research trials, such as maybe Envision, and you're looking at, or you want to use an Abbott Navitor valve, and you say, hey, the patient can't get that. The STS is 3.7. That's not high risk. You look at this, and that's an 85-year-old with multiple comorbidities, concomitant mitral regurgitation, coronary disease, calcified arteries, PAD. It's not a low-risk patient. So you can actually look at all the data and say, hey, this is actually a high-risk patient. I would put them in this category. That frees up the valve selection choices that I can make. And then bailout, we also talk about, we do our STS salvage score, and we talk to patients about this. When we're offering them a SAVR versus an emergent sternotomy in an emergency in the OR. And then hemodynamics. If you're a believer in EOAs and choosing valve selection based on that, we always have our hemodynamics choices. And then we really discuss true procedural considerations. Do they have a horizontal aorta? What is the calcium burden? Do we need to use sentinel for this? Access considerations? We're talking about all of that. Once you get this down, this takes 2 minutes or less, okay? It takes me a lot more time to put it together in the background, but it takes 2 minutes to discuss this, and you're really going in depth discussing this patient in a heart team discussion. And then you say, well, what about more complex patients? What does this look like? So now this is a 72-year-old patient with a valve-in-valve, same discussion, same strategy, and we can still get through that patient very quickly, looking at all of the data that's important to know. And what does the future look like? This is not a DASI talk, but we use a lot of DASI when we are making valve selections. And so in our valve conference, our heart team discussion, we will pull this information up and we'll look at different types of valves based on that patient's anatomy and see what we can do. You can also have valve-in-valve implants that we can look at for future valve planning. We can look at risk of coronary occlusion. We can look at PVL risk, gap analysis. We can look at risk of annular rupture. So this is just one tool. It's not completely validated yet, but this is what the future of structural heart and heart team discussions is looking at, right? Incorporating all of the data that you have access to into that discussion. So tying it all together. At that heart team discussion where you have all of the players at the table, you're talking now about lifetime management. You're talking about rhythm management. Would this patient do well with a pacemaker? Would they be able to keep up with them? Does that fit their quality of life and is consistent with what they want out of this procedure? You're incorporating advanced imaging, making sure you're not missing anything. You're talking about bailout sternotomy. I know when you're getting creative and you don't have a cardiac surgery team as a backup now, and you're moving into that cath lab space, now you're really getting into the details of, hey, I can schedule these patients in the cath lab, and these patients need to go into the hybrid. So you now have the ability to make those decisions at this meeting. incorporating risk level. Is that patient truly low risk? And then research, having your research coordinators there and pulling them into studies as you talk. So ideal meeting, it's an ideal meeting for providers because it creates reproducible results. The patient is leaving with a plan. It's not based on a single person's schedule. So if your IC is different that day, you're still having your heart team discussion, you're still coming up with a plan. It's a decreased burden of paperwork. There's no paperwork. It's all electronic charting. It's easy documentation. It's compliance in the chart. We have CME approval now for it, so we just sign our name and we get CME hours for every time we attend. It's an open invitation. It's a great way to get your referring providers involved. All of your subspecialties are invited. If you have a patient that's really tricky and you say, hey, for your vascular surgeon, I want you to come. I have this patient I need you to evaluate, they'll be there. And then it's an ideal ideal meeting for patients because all key stakeholders are at the table. It's an in-depth review of the patient. The images are available for review with the patient. So that PowerPoint slide, I actually put into Epic. It's available. So when the patient calls and says, why did you make this decision? I can refer back to it, and all of my notes are right there. And then you discuss complex issues. You're looking at lifetime management, you're looking at alternate access, and you're looking at valve and valve. So it's a comprehensive multidisciplinary review, and you want to be compliant. So I'll leave you with this. It says, success is often hidden in the smallest details. It's the careful attention to the overlooked that turns good work into greatness. Thank you.
Wow, it was an incredible talk, Sarah. I think many of us, well, you answered my first question. I was going to ask who did that slide. So I'm sure that takes an immense amount of work. But, I think many of us are vested in contemporizing the heart team meeting because old habits die hard. And I think that, as we're seeing more patients are being referred, the agenda gets longer and longer. And so I took away a lot from your talk because I think that, again, to have just a very efficient and streamlined meeting, and especially incorporating EMR in that, that's incredible. So I don't know what anybody else's thoughts are.
Same thing, our heart team meetings were upwards of 2 hours. You're there for so long. So we actually made some guidelines in our own team to say if it's a very straightforward case and we see them in clinic and we have a surgeon, an IC, myself, a valve clinic coordinator, our imager is there, our heart failure team is there, we do a heart team meeting right then. And we sort of made these guidelines for our team. So it's actually brought our heart team meeting down to about 45 minutes in discussing about 20 cases in 45 minutes. Same exact slides, same thing goes in the EMR. So we have some guidelines that have really helped us streamline that process.
I'll just mention one thing real quick. So we also have been working on trying to streamline and optimize the heart team meetings, and we have Epic and being able to create a jot sheet, as I call it, which is a one-pager that is automatically able to pull a lot of the information that you had on the slide on there. So it saves a lot of time because before that I would do PowerPoints for everyone. I'm still a PowerPoint lover. But it really made things a lot more efficient where you just see the key points that you need to know, but it takes maybe 10 minutes for me to make because a lot of it's pulled automatically through the EMR. So just another thought if you were able to embed it and incorporate it in your EMR system.
I've got a question. Sure. The CME credit.
Yeah.
That's awesome.
Yeah.
Do you feel like that really engages the entire team?
I don't know if it increases attendance or not. To be honest, I think it's an extra perk. We all are pretty much invested and want to be there anyways, but I think it does help for, other APPs who may just want to listen in, and then the bonus is a CME credit, absolutely. And anyone who listens in, who's not used to listening every week, learns something. So it's a pretty incredible opportunity to get everyone together and involve everyone. And I will say for the cath lab team members, the amount of valves that docs love to change valves the same day. We don't do that anymore because we have these in-depth discussions, and the cath lab team has loved our change in heart team discussion because of that.
Bringing in your referring providers, I think, is great too. So they actually get to see exactly where your thought process was. They know what's going to happen. They have the plan. So when the patient follows back up with them, and they have questions that maybe they didn't ask you in that follow-up, that team was also aware of exactly every step along that way. So that's been really helpful for us as well.
I think it is another perfect example of, there is no one size fits all for every single program, but bringing back Liz into this discussion, I think that, I think collegially, if we come together as a group and figure out better and efficient ways of doing this, that this may be more of a universal model for programs to adopt, because it's kind of all over the map. So thank you again. Appreciate it. So I have the pleasure of introducing our next speaker, Kate Reen. If we can bring her slides up. Congratulations on your new APP Scholar role. And she is the clinical lead and director of strategic and programmatic initiatives at Mass General Hospital in the structural heart program. And she's going to talk to us a little bit about incorporating our interventional heart failure colleagues into our programs.
It's on, great. Can you hear me? Perfect. So thanks for having me, Marcus. Thanks for the invitation. Excited to be here. So Kate Reen, I've been at Mass General now this is my 19th year, always with the structural heart program. We have a pretty robust program, same as Sarah, I think 500 TAVRs, about 100 mitrals, tricuspids. I've been the only APP for 15 of those years. We do have 2 structural fellows, but Monday, a brilliant, fabulous APP walked into my office that we just hired, and I gave him a hug, and we're gonna have help. So, understanding how these heart teams, sort of migrate and evolve over time is really, really amazing to watch. So we're gonna dive in here to see a little bit how we're bringing our interventional heart failure teams. These are not...
I need some help advancing here.
I went to ACC, and these new people were there, these interventional heart failure specialists, and I was like, who the hell are these people? So, I was just kind of wondering where this came from and where, what was the background of it? So, interventional heart failure has sort of emerged as this critical subspecialty. And I think the increasing complexity of heart failure treatments, now spanning with pharmacologic and non-pharmacologic, device-based therapies, has really born this new breed of physicians. So you'll see that, this initially existed at the intersection of interventional heart failure and advanced heart failure, and it sort of expanded to encompass multiple domains of cardiology, and now we see them here in transcatheter valve therapies. So what you'll see here, we all are very aware of this slide. We know that valvular heart disease advances with age. We also know that heart failure advances with age. So the involvement of these 2 disease processes together has highlighted a new burden on patient and healthcare teams together. Transcatheter valve interventions in heart failure, being able to follow our heart failure patient through their journey from when you meet them in clinic to when they go to the cath lab, whether it's for advanced hemodynamics or whether they're coming for a coronary intervention, or maybe it's a structural intervention. It's an appealing process and it's gratifying, and I understand why these dual-trained physicians have gone there. But despite the numerous options at our fingertips, these measures can at times fail to target both the heart failure and the structural heart disease. So I think it's important to know that while we have both teams, we are still 2 different specialties, but we're still, trying to live in the same tree at the same time. So this interventional heart failure is this rapidly evolving subspecialty. We have people in our community now that it says it on their coats. So this is a new thing. It's a new degree you can actually get. So it bridges the gap between advanced heart failure, cardiothoracic surgery, and interventional structural cardiology. These are the interventional heart failure teams. We have now incorporated them into every part of our meeting with every patient that we see for our mitral and tricuspid patients. They are part of our heart team. We have a GDMT APP run optimization clinic that all of our mitral and tricuspid patients prehab with before they come to see us in our clinic. It's been absolutely amazing. So the significant growth due to this increasing prevalence of heart failure has really been something that we've watched over time in our program, and we're actually welcoming it. So one of our interventionalists described it as sort of this, they were plagued by not knowing where to go. It was like a bird and a fish who fell in love and couldn't be in a relationship because they didn't know where to live. That's what they described it. So, and it makes sense to me because that's where they don't really know where to go. But bringing them in as part of your heart team with your EP specialists and now involving them has really changed the game. So I'm going to take you on a little tour. We're going to go for a little trip around the heart here. So we're going to start with our tried and true aortic valve. So, pretty clear, and we're all advanced practice here. We all know what we're talking about. So clearly, when discussing aortic stenosis, the causation towards heart failure is evident, right? So with increased afterload leading to concentric hypertrophy, thus reducing wall stress, worsening diastolic function. Eventually, we end up with LV systolic dysfunction, chamber dilatation, and myocardial fibrosis. So at MGH, we saw this process happening, and we were seeing that the prehab wasn't really working for either aortic or mitral tricuspid patients. So we started this APP-run GDMT optimization clinic. Heart Failure had their own clinic, and we sort of borrowed a couple of their people, and now we're just this one big clinic. And they help us from the pre-side, peri-procedurally, and they see our patients post-procedure. So it's been really amazing. Just a show of hands, does anybody have a GDMT clinic in where you're practicing? Yeah, and how do you use it? Do you mind if I ask?
We see them for MR.
Yeah.
After the T, if they're secondary, they go through the GDMT.
Okay. Anybody else? Anybody else have one?
Ours is derived from, again, I kind of highlighted it, but it's called the CHAMPS clinic.
Yeah.
And so usually if patients are admitted for acute heart failure,
Okay.
they would see an MP or APP after their admission, and then it's kind of alternating visits between the heart failure doc and the APPs. So
Yeah, and they're part of your care team. They come to your meetings and all
Absolutely.
that. Yeah. So, when we think about this, left-sided chart here makes reference that 25% of TAVRs have a low EF, right? So the bar at the bottom on the left side of that chart there shows that patients who start with an EF of 50% usually show an improvement at the 1-year mark. The top bar predicts that the patients with an EF of 60% usually sustain that normal EF at that 1-year mark. The right graph shows that having a low EF doesn't actually worsen your prognosis because it's expected to improve. So when we look at those patients, you'll see that all of those groups have the same survival there when we're talking about normal EF in TAVR and in SAVR. So we'll look at this one here. Noted here is, when we fix the valve, the EF improves, but many patients come back still with heart failure symptoms. So it's often almost 25% of those patients or 50% of those patients come back with heart failure symptoms again. Who sees those patients when they come back? Do they come back to the ER? Do they go back to your GDMT clinic? Do they come back to us? We sort of made a post-procedure, EF reduced GDMT clinic. We have one NP that runs it. She's on call all the time. God bless her. And she sees all these patients. She's the one that's in charge. But it's really been, understanding that a number of these patients still have an element of diastolic dysfunction that's not usually treated. When we think about this and we're moving towards earlier treatment stages, we're recognizing that these symptoms are going to come back post-TAVR because we haven't really fixed the problem. So you'll see here these NYHA classes, the vast majority of patients in class 3 and 4 heart failure, they do come back at 1, 3, and 5 years, usually in a class 2, but there are those outliers there that you'll still see in class 3 and class 4 heart failure. So moving on to mitral here. Among patients with heart failure that have mitral regurgitation because of that LV dysfunction, the prognosis is poor. We do have transcatheter mitral valve repair, which may improve clinical outcomes. And we all know that the mitral valve is a tricky valve. How do I go back? Can I go back one? Yeah. So we call it the Moody mitral at Mass General. So, there's just so many things you have to know about the mitral. It's not round, it's not D-shaped, it's asymmetric, it's not flat, it's saddle-shaped, it's annulus, it's a dynamic annulus. It's not passive, it contracts, reducing that valve area in systole. It's a high-pressure closure valve, not a high-pressure opening valve. There are 24-plus chords there that you have to navigate. It's really hostile in there. It's relatively easy to block aortic flow. It's much larger annulus in the aortic valve. So mitral regurgitation is not one disease. There are many things that lead to that. So when we talk about this with our teams, we bring in our heart failure team, and we describe that the primary MR is the valve, the secondary MR is the heart. And secondary functional MR increase the severity of volume overload that's been strongly associated with decreased quality of life, an increased rate of hospitalization for heart failure, and shortened survival. So, these heart failure teams really take a really keen look at these patients. GDMT therapy, again, 20 of Lasix every other day, not weighing themselves. They don't take it because they came to the appointment. They don't take it because they went to, gamble or something, whatever they're doing. But, they're not taking it. And I think, educating the community has been a really big part of our job in the past year or so with this rise of mitral and tricuspids. So we know that GDMT may provide symptomatic relief. It may improve that left ventricular function. And in some patients, it may lessen the severity of MR. We know here that 70% of patients with CHF have some degree of FMR. That main focus for our heart failure team is usually functional MR, noting that decreased contractile force, increased annular dilatation, and that leaflet tethering, all leading to that reduced leaflet coaptation. So you'll see here highlighted when you sort of add MR into heart failure, it worsens that prognosis significantly. Seen here on the left panel, the chances of a hospitalization-free survival in patients with heart failure is better when they don't have MR by about 40%. That's a big number. But if you have severe MR, your survival at 7 years is less than 20%. So the ability to stay transplant-free was higher, seen on the right panel with less MR. So really noting that EF really closely tracks with survival following surgical MV repair or replacement, and those low EF patients are really high surgical risk candidates. So the current therapies for MR, we all know them. There's medical therapy, there's transcatheter therapy, and there's surgical therapy. So why do we need transcatheter therapies? You know, comparing these three options, the medical therapy being the least invasive, but surgery providing the most predictable relief for MR, a transcatheter patients really sort of live in the middle there, where we're trying to do as much as we can. The technological advances are allowing for the development of multiple devices with significant impact on mitral insufficiency at a low procedural risk, right? So we know that we have low-risk patients and the high-risk patients, and that's where that balance is. And I'll tell you, our mitral and tricuspid visits are longer than our aortic visits. We're in there for at least an hour. We have a full heart team meeting. We tried to get more patients into our clinic and cut our visits down to 45 minutes. Couldn't do it. There's just too much to talk about, right? We go in there with a team of 5 people. We're in there for about an hour and 20 minutes per patient. So when we see mitral edge-to-edge repair TEER here, we know that that's a concept based on a surgical repair technique, which establishes that vertical coaptation while capturing the leaflets and drawing them together, having the ability to reposition and allow for real-time MR assessment prior to deployment, right? So shown here is the MitraClip system, and also in use now as the Pascal system. So when we look at all-cause mortality, we know that increases with multiple hospitalizations. Thus, the co-op trial was born. Among patients with heart failure and moderate to severe or severe secondary MR who remain symptomatic despite the use of maximal doses of GDMT, transcatheter mitral valve repair resulted in a lower rate of hospitalization for heart failure, lower mortality, and a better quality of life and functional capacity within 24 months follow than GDMT did by itself. So when we look at primary effectiveness of that endpoint there, COAP trial really sort of spearheaded that transcatheter edge-to-edge repair of secondary MR, evolving structural and valvular interventions targeted at heart failure patients across all ejection fractions and further intensifying the need for interventional heart failure specialists to remain a part of our team, right? So 5-year results of the COAP trials show that the benefit of structural heart intervention for heart failure, including a durable 47% reduction in death or heart failure hospitalization when compared to the pharmacologic arm by itself. So when we look at first post-procedural MR TEER impact survivals, despite our best efforts, we still have a fair amount of patients that have 2+ or 3+ MR after a mitral intervention. We need to think of better therapies. These are all on the market, and everybody's looking at them. They're everywhere. The only one that I did not have time to find a video for was the ENCIRCLE. But you know here that when you have a 2 or 3 grade MR after a TEER, you have a bad prognosis, right? So we need therapies better for TEER that are reduction and seen here as valve replacements. One thing to note is, when we have our patients that are coming in with low EF, because the valve, we have that sort of increase there of afterload in the heart, you can see that temporary decrease in their EF. And sometimes, so this is at their 1-month follow-up, and sometimes we think, oh goodness. And then we bring them back at 3 months, and you'll see that it's sort of come back and it is recovered. So, giving your patients a little bit of time for late recovery has been practice in ours, and we've changed our follow-up as such. So moving on to the tricuspid valve, which is the forgotten valve, it's definitely having a glow up, as the kids call it right now. So its impacts on long-term outcomes. We know that there's a misconception that TR has no real impact on patients. We've always ignored it. If we went back and look at all the echoes that we've looked at for our mitral and aortic patients, they all had some degree of TR. Everything is there. We're just paying attention now. So, look at this study here. The mean LVEF was 50 to 55%. The survival was worse for patients with increasing degrees of TR. So do I think we have a lot of work here? I think we do, and I think we have a lot of knowledge to gain. And I think it will come. I just think, again, not doing these procedures because we can do these procedures, I think was a great statement. And I think a lot of programs are doing that to keep up with star ratings and all these things that we're trying to keep up with. So I appreciate that somebody mentioned that before. I think there's a lot of work there that we need to do. So wrapping up, let's see, here we go, conclusion. So we know valvular heart disease is prevalent in our heart failure patients and impacts survival. We know outcomes are dependent upon procedures and interventionalists and your heart team. And I think our goal as members of an inclusive multidisciplinary heart team should be to reduce early readmissions, reduce late heart failure hospitalizations, reduce heart failure mortality, and in our structural heart population to continue to evolve and include interventional heart failure as part of our heart care team. I'm from Boston, and that was the fastest I could talk. Okay, thank you so much.
No, you did great, Kate. Round of applause for her. I think one of the hugest takeaways that I take from your talk is just that, I think a lot of times we think that these therapies are just magic bullets, right? And that the patient's going to walk away and feel like $1 million. But I think when I talk to patients preoperatively, I tell them we see all walks of life, right? So sometimes people notice immediate differences in the days and hours after these therapies. Sometimes it takes time, therapy, rehabilitation, but I think the interventional heart failure component of this and consistently following these patients after these treatments is just really, really huge. So kudos to you and your program for doing that.
And I think setting expectations at those visits is very different. Your aortic patients, you're going to say, in 2 weeks, you're going to be great, you're going to feel good, but these patients are going to come back. You might not feel great right away. So setting that expectation for the patient and the family, I think is important at these visits, which is why they take so long.
I was really excited to see your talk on the schedule. So I was a structural heart nurse practitioner embedded within an interventional heart failure team. The name of the department was Advanced Cardiopulmonary Therapies and Transplantation. And so when referring physicians see that, they like sending very advanced people. And my joke was always, it's okay if you send them if they're not really advanced. Like, we still take them. So it's love to hear your talk. I definitely think it's an emerging specialty coming out. I just wanted to kind of ask everybody's opinion on this. We've always heard that the tricuspid valve is kind of, like you said, the very ignored valve in the heart. I was shocked as we started going through those tricuspid therapies how incredible these patients are doing afterwards. And just seeing almost just those immediate benefits. And I thought, I can't believe we were really ignoring this for so long.
I would say it's hit or miss in my experience. I mean, some, yes, they do fantastic. They don't require paracentesis anymore. You're changing their life. And then others, they're like, yeah, no, I don't feel any different. I'm like, oh, your echo looks better. I don't know. But I mean, that's what it takes time. It takes time. It takes managing their medicine over time, and they will feel better as their RV remodels and it's happier. But I would say I have mixed follow-up.
And I would add to that, I mean, I think that these therapies, again, are in their infancy. So, as far as proficiency goes and outcomes go, I think that the sky is the limit at some point in time, but we have to be really careful and cautious about how we proceed. I mean, I think the best data that we have right now is quality of life improvement. And when you're 80 and 90, I think that's a huge thing, right? But, some emerging data suggests heart failure hospitalizations are less. But if we can get to the mortality benefit and things like that, like it potentially could be a game changer. So Natalie, what do you and Misty, what are you guys seeing?
I think the biggest point that really you made was like setting the expectation, but also having a good foundation in your structural program really sets you up for this type of growth, the tidal wave.
I want that GDMT person.
She's amazing.
That sounds incredible.
She goes on vacation, we're like, oh God, what are we going to do? So a couple other things that made us do, we, just from a tricuspid standpoint, we had to change our practices a little bit. Like patients coming in for CTs, we had to implement them getting weighed before they were getting their CTs. And that took a lot of this GDMT person being with us to go down to CT to say, this is why we have to do this. It's really important why we're changing practices here. And you're bringing different heart team members into your clinics, right? So people don't know who they are. So it's really that exposure for the heart team being more than what you are usually having at your visits. And that takes a longer time, but it takes a lot of education.
What are you guys doing with diuretics post-clip and evoke? I know there's some data to suggest, doubling them or, increasing them for a short amount of time.
Well, the overall sentiment, again, is the magic bullet where they say, oh, I got my valve treated and so I can stop my diuretic. But again, I think just looking at the real-time hemodynamics in those patients is pretty huge. And I think that's where I have an advantage in my role as being a participant in the therapy and understanding what their baseline pressures are as well as what they are post-intervention. And it really kind of helps guide the therapy. But just like Natalie said, I think it's about, setting expectations and talking to to the patient, up front and letting them know, this is an ongoing battle. Just because we treat your valve doesn't mean that all of this is going to stop. The important lessons that we've instilled in you are going to be just as equally important. I think the crux is, and to Kate's point about the heart failure specialists, is that, typically we see them back for a 30-day follow-up, and then it's kind of like general cardiology or as needed within the valve clinic. So I think there is a real means for a pathway that, you can derive care that's consistent over the course of time, for a year or more, right? So.
I think the other thing, it kind of brought me back to those nursing roots where when you get your mitral and tricuspid patients in, it's really fascinating to me what they think they're taking for a diuretic versus what they've been told they're taking for a diuretic, which is what they bring into your visit. So like going back to actually saying, do you take this Lasix every day? Like it really have to really, really narrow down on that. And all these visits take a lot more time and they don't really understand why they're taking these things sometimes. So really going back to that sort of base understanding of explaining things to your patients and understanding what they understand.
Well, great discussion. I'd love to keep going, but I think we're going to keep, in the interest of time, keep going. So we'll move to our next speaker. I've got the pleasure of introducing Courtney McAlister. She's a DMP, and again, as listed, she used to work at UT, but has moved on to industry. But she's got a great presentation for us here today, and looking at identifying or predicting LVOT obstruction after TAVR. So thank you, Courtney.
Absolutely, and thank you, Marcus. I really appreciate the invite. I'm really excited to be here today. As Marcus said, I left UT Health a couple months ago and joined Anteris Technologies, and I know Marcus and I kind of talked about me possibly speaking about my transition in industry, and we're not going to talk about that today, but if anyone's interested in speaking with me afterwards, I'd love to talk to you about it. It's been a great experience being on a clinical research team, kind of being on the other side. So I'm here today to talk to you about patients at risk for left ventricular obstruction. And this is something that is kind of near and dear to my heart. It's a project that I did with my team before I left. And it's something that I feel really shows like what the people that are in the engine, if they really speak up and take action, how much that they can create improvements in patient care. Okay, so what started this LVO talk? A couple years ago, we actually published a case about a suicide ventricle following protamine administration in a patient. This patient had severe LVH, got through the case, was a straightforward outpatient TAVR. The patient was pushed protamine. Protamine was pushed pretty quickly. The patient developed a suicide ventricle, went on ECMO, was hospitalized for 2 weeks afterwards. Probably took him about 3 to 4 months to get back to baseline. So something that should have been a really straightforward procedure turned into a pretty big problem for this patient. In the meantime, we're publishing this case report, and a few other things were kind of going on that I was taking notice of. So kind of like at the end of some of our cases, I was noticing the patient's pressures were kind of soft, and we were kind of making decisions whether they should be going to ICU or they should be recovering in our PACU unit, but we couldn't really find any good reasons for why their pressures were soft. We were having some hypotension immediately post-valve deployment, and patients were requiring ICU beds. I was getting phone calls from the echo techs 24 hours afterwards, and they were saying, hey, these gradients are really elevated compared to what they were immediately post-procedure. And then I noticed that our IMU APPs were kind of inappropriately treating some hypotension after the case. Okay, so I'm tying this all together, and I'm like, man, we really have a problem with left ventricular obstruction patients, right? I work for advanced heart failure team, a lot of HFpEF people. So I dove deep into the literature, and I looked really at the incidence. What's going on with LVO? And there are, varying percentages of patients, but the best data that I found that this can occur in about 13.3% of patients after TAVR. So, and if it does occur and a dynamic intraventricular gradient is created, as long as it's treated well, the patients have good outcomes, right? But you have to treat it atypically than you would treat general patients with hypotensive that don't have hyperdynamic LVs. Okay, so really the problem we all know pre-TAVR, aortic stenosis causes high afterload on the left ventricle, thickening occurs at the LV, you have increased LV mass, and then when we immediately relieve that obstruction and when the valve is deployed, patients that had those really hyperdynamic left ventricles can start obstructing. So their EF can go up 80, 90, even like 100%. This patient on the right-hand side is a patient I had, their baseline EF was 65 to 70%. You can see it's pretty much 100% post-TAVR. So the patho behind it really, when we talk about left ventricular obstruction, everybody thinks it's LVOT or left ventricular outflow tract, but really in the literature, post-TAVR, 95% is really happening mid-cavity. So, when I used to hear LVOT, I used to think of like our TMVR patients, right? Or like our neo-LVOT patients. I really didn't think of our TAVR patients developing it. So, and the treatment is really counterintuitive, right? These patients have to be preloaded with fluid. They are very preload and volume dependent. You cannot push protamine fast. We all know like vasodilation with protamine, it's a problem. I don't know about all of you, but our anesthesiologists push in about a minute or two. That's what they're used to doing in the OR. That's what they do down when they're in the cath lab, when really you're supposed to administer it over about 15 minutes. And then you cannot use positive inotropes on these patients. Giving them epi, norepi, these things that are causing an increase in squeeze when they're hypotensive is actually creating a worse problem for the patient. You need to use phenol, you need to use vaso, and if they're tachycardic and hypotensive, it's really uncomfortable, but you have to beta block them down because they need that increased fill time of their left ventricle in order to increase their pressures. Okay, so I was like seeing all these problems. I'm like, okay, let me dive into our anesthesia records and our TVT registry data. And I was like, oh boy, do we have a problem. So patients that were really at risk for left ventricular obstruction, 55.2% of them were receiving positive inotropes. Yikes. And the prevalence of hypotension post-valve deployment was about 41.4%. And we, kind of the operational definition of that was 5 minutes post-deployment, if their MAC was getting less than 60, we were counting that as hypotensive. Okay, so pulled all the APPs together, structural APPs, pulled the coordinators together, and I'm like, guys, we have a problem. We've had some really bad patient outcomes. How are we gonna prevent this? We don't have a whole lot of resources. I know we're all really, really strapped for resources right now. I don't want to add any additional workflow to these valve clinic coordinators. They're super stressed, they got a lot going on. That is one of the most respected jobs on the heart team, right? I love my VCCs. We don't have a system in place to identify these patients up front. I'm in a really high acuity TAVR center, academic, a lot of fellows, residents are touching these patients, and there's really a minimal understanding of left ventricular obstruction after TAVR. So once these patients leave the cath lab and go to PACU or IMU, they're really being managed by other teams other than our structural team. So dove back into the literature, and I was trying to find identifiers with the data that we had. Right, we know we have an echo, we know I have a CT. Based off the echo and the CT, what can I use to possibly predict these people? And guys, I got really deep with this. It was all over the place in the literature. I'm looking at ECG criteria, looking at LV voltage. I went super deep. Bottom line, there is not any good predictor, so I said, forget predicting. We just need to identify at-risk patients. And when we talked to the team, looked at the literature, we're like, okay, we are gonna flag patients that have an EF of 65 to 70 or greater than 70%, or have an LV EDD less than 42 for males, less than 38 for females. So it's essentially our ASC criteria for a low LV. And we developed an alert system, and it's called the Hyper LV Alert. Notice a lot of this stuff is pink. That was the coordinator's idea to make it hot pink, okay? There was a vote, and sorry, Marcus, there was only one guy on board, and the rest of the girls said, we're going with hot pink. So what we know about doing QI is education is not enough. I can't go in and tell a provider like, hey guys, this is how we're treating these patients. We have to create a system to prevent fallout. So what the coordinators did was when they were screening the echo initially when we got the patient in clinic is they would flag the patients. It would go on our one-pager. I loved hearing about the one-pager because we had a one-pager too. And it would follow the patient throughout their hospital stay. When we scheduled the patient in the cath lab, it would go on the OR tracker that the cath lab cases were scheduled at. It was announced during timeout in the case, and then it went on the handoff communication tool up to the ICUs. Oops. Sorry, thing's a little jumpy. Wow, I'm really screwing this up. Sorry, guys. I did it like once and it goes like a little crazy. Okay, so here's just kind of like a picture of our OR tracker. My coordinators had little stickers just to remind them, hey, who we're identifying up front on their computers, and our little one-pagers were up on the wall in the cath lab. So our goal, because we're doing QI here, we wanted within 6 months of implementing this Hyper LV alert system, we wanted to successfully identify 50% of patients at risk, and we wanted to reduce the incidence of hypotension, by 10% and the positive inotrope usage by 10%. I don't know if anyone does a lot of QI out there, but when it's 10% sounds small. When you're trying to change people's behavior, that is huge. Usually a 5 to 10% range in QI that's a big number. Okay, so how did we do? After about 6 months, pulled back up the TVT registry data, pulled up our anesthesia records. So when we're looking at qualifying metrics for patients, 22.2% of them qualified based on EF alone. That tells you how sick the population is that we're treating, right? 44.5% qualified based off LVEDD, and then 33.3% of the patients at risk actually had both. Those are the really scary patients. So no surprise, a greater majority were female patients, and we successfully identified 80% of patients at risk. Remember, our goal was 50%. We successfully reduced our positive inotrope usage by 20.2%. That is huge, simply by putting an alert on a patient, right? How did that affect our outcomes? We reduced our incidence of hypertension by 21.4% in these patients, also very, very big. This is something that's so easy, so easy. I didn't add any work to my coordinators. All we did was look at an additional echo measurement and literally put some verbiage into some education, and we made such a huge impact on these patients. So really lesson learned, something I really saw going through the data, treatment is really provider dependent. At my site, I had dedicated CV anesthesiologists, and we were still giving positive inotropes on these patients. So you really think, hey, everybody knows knows how to do this. Honestly, don't take it for granted, right? Really pay attention to what's going on. Something that we also started noticing is we were really observing LVO in TMVR patients, not obstruction, not neo-LVOT obstruction, actual LVO in our TMVR patients. And I don't want to name the company, but one of the companies, I was at their PI meetings for a TMVR device, and they're actually talking about closing off these ASDs in the TMVR patients almost immediately because these hyper-LV patients lose their preload when they're shunting post-procedure when you have these really big ASDs. So this is really kind of like coming into play. And as I'm sitting in that meeting and I'm listening to all these doctors, one of the doctors kind of raised his hand and he said, our ICU team doesn't know how to manage this correctly. And I'm like, I feel you, trust me. I just went through this with our TAVR patients. Protamine is an issue for the hyper-LV patients and the non-hyper-LV patients. When I went back and looked at our anesthesia records, everybody was dropping their pressures when they were giving protamine. So it was a huge education thing for us that we needed to discuss. And finally, as we get kind of next generation TAVR devices going, we're doing a better job offloading these LVs. I think we're going to see an increased prevalence in LVO, and so it's really something to pay attention to as you're screening these patients and treating them intra-op. These are my references. Thank you very much.
Thank you, Courtney. That was phenomenal.
Yeah.
Again, I loved how it convalesces over the entire treatment team, not only just the treatment team within the cath lab, but the ICU staff and the nursing staff too. The point that I thought about too is that, with many programs transitioning to using nurse-led sedation and having TAVR be performed more of a cath lab type procedure, I think that does remove a little bit of variable, and I'm interested to hear what the rest of the panel has to say because, at least in my experience, I think our anesthesia colleagues, don't get me wrong, they're great, and when we need them, we need them. But when TAVR is performed with cath lab nurses, they're very good about communicating and discussing and those kind of things. And so I think that sometimes anesthesia is really quick to push those pressures. But the big point is just the pre-identification and identifying that subset of patients, and whether that's within the heart team meeting or pre-procedurally or otherwise. I think that as long as everybody is on the same page, that you can really avoid some big dangers there. So.
No, absolutely agree. And a lot of times all these TAVR centers are doing 6, 7 cases in a day now, right? So it's kind of like why you start getting to the end of the day, the patients have been NPO, everybody's kind of tired, and you're forgetting those little details that can make such a huge difference in patient care.
Any thoughts?
Yeah, no, I'll never forget one of the patients. Like you, Marcus, I scrub all of the procedures, so I'm first assist in the OR, and I'll never forget the patient where you come in for their TAVR, they've been induced, and it's this just kind of slow burn hypotension. and you're like trying to catch up the whole time. You just can't even get there. So, and sometimes in these patients, identifying it, I believe, at that heart team discussion, looking at the echo, putting it in bold on that slide that's up in the OR so that anesthesia knows, incorporating it into your timeout, this is your method, this is what you're gonna do, is huge. And then one of the tactics that we'll sometimes do if we're really worried about it is we'll balloon the patient. If it's a high-risk patient, and kind of see how they do, let them recover from that before we TAVR them.
Absolutely.
I just wanted to mention thank you so much for this talk, and this is something that we have seen in our center as well, and I am from a smaller community hospital, and at our facility, if we don't have anesthesia booked in the room, they're going to be booked elsewhere, and they will not be available for us. And so trying to do nurse-led sedation is not something that has been extremely feasible for us, but the protamine discussion has really been a hot topic. Whenever we first started, there was no set protocol as far as how much anesthesia was giving for protamine, and then I would say within the past couple of months, we really have revisited that, where during the case, our ICs and anesthesia are conversing about it openly during the case to discuss the correct amount or the appropriate amount to give for that patient. So including them still in that conversation, we have found to be really helpful, and then also identifying those patients that are at risk ahead of time. I communicate that a lot of times with the anesthesia the day before, so they have all the available meds available in the room in case that patient does have a suicide LV. So thank you again for highlighting that.
It's a great point. Testos, right?
I think also noting that a small change made such a big difference, right? We all think we have to make these grand sweeping changes to make something happen. It took a couple sticky notes, you going in to talk to people. So like recognizing the things we do day to day, it doesn't have to be this grand movement. It can be these small little steps that make such a big difference. So well done.
Absolutely. We are very powerful in what we do every day. Thank you.
All right, we'll keep on task. Thank you, Courtney. And we're going to move to our next speaker. I have the pleasure of introducing Natalie Kelly. She is a nurse program coordinator extraordinaire. Had the fortune to work with her on many ventures within Medtronic, and so she's going to really dive into the TVT data and shaping our excellence within the structural heart program. So thank you, Natalie.
Awesome. Thank you, Dr. Burns, for the invitation to speak. My name is Natalie Kelly, and I am a registered nurse and the valve program coordinator at Christus Heart Hospital in Tyler, Texas. I have been in this role for a little over 7 years now. And really, after spending so much time in the role as a VPC and also as our TVT abstractor and data manager, I've learned that really quality is way more than just a score. It's definitely how well your entire program functions. From the initial referral, designed around patient outcomes, your system efficiencies, and then really just sustainable performance. It's quarter over quarter. It's not like a report card like it used to be whenever you just got your report. Now it's dynamic, it's constantly updated, and you have all the access to your data. A little bit of background, I work at a community-based hospital about 100 miles east of Dallas, and our program looks like 2 interventional cardiologists, 2 hospital surgeons, a structural heart cardiology nurse practitioner that joined our team about a year ago, and then me, the valve program coordinator. My roles include all things TAVR and TEER, and then also big on data, registry manager, and I abstract all of our data. So that's really what I want to share in this presentation is how data isn't tracked, it's honestly translated, and how the work that we do as heart team APPs and coordinators, this is something that differentiates our role. It zooms out on from beyond procedure day and definitely separates, I think, programs that do TAVR and do TEER and do all of the clip therapy to truly robust structural programs. So a little bit about the registry manager role. Managing the TVT is more than just punching in the data. It's really active, ongoing assessment of your program and how you perform against the nation. Part of my job is ensuring data integrity, timeliness, and that completeness, because really these numbers shape our outcome reports, which then has a direct impact on our public reputation. I think that my clinical background definitely informs our operations. I ensure that the data is entered with integrity, and I also coordinate with the heart team just to ensure that documentation accuracy. So some examples include coding for bleeding and stroke and these things that are heavy hitters on your registry outcomes, that's really something that, as a valve program coordinator and managing the registry, I identify patterns before they become problems. And that's a huge takeaway, I think, whether you have direct oversight of the registry or not, having that high-level ownership amongst the entire team is so important. Outcomes are now publicly reported. You can choose to opt in for this, and we'll kind of get into a little bit more of that later on in the discussion. But I want to connect the dots, connecting data to decision-making. And really, the registry is only useful if the data tells a story. And as a valve program coordinator, we have that unique opportunity. It's something that differentiates us in the role. So my role connects the dots between these registry metrics and then the real-time workflow changes that we do during the day-to-day. We turn this retrospective data into really prospective improvement. And like I said, used to, the registry felt like a report card. It was like blowing up in your email, boom, you got your report, and you're like, oh no, let me go look and see how we did. And now you know what's going on. It's live. But it also, I think, drives the accountability because you need to ensure that you have that passing rate for completeness. You've got to have 90%. So that means like all of your streamlined processes, they've got to be A1, especially for programs. We do about 100 TAVR a year. So each patient counts. And so you want to be sure that you have the green boxes, if you will. Every quarter is green. You have that 90% passing rate. But that's also a huge, I think, a win for you and things that you can speak to as a valve program coordinator is that that's your work. That's your processes and your efficiencies demonstrated on a national stage. So I also want to just talk a little bit about follow-up compliance and how a lot of times as the registered nurse and program coordinator, you think, okay, I'm scheduling, I'm doing all this. It's like, got to get all this done and schedule all these patients. And really your patients compound. You have your referrals coming in, but those turn into 30-day follow-ups that turn into one-year follow-ups. So as you continue to work and grow, the work compounds. And so you want to ensure that you have that follow-up compliance. It's really about program commitment demonstrated in the registry. So I would challenge you, go home and look up how many patients roll up for their 30-day appointment and then their one-year appointment. This is our data. It's really on the front page of your registry. There's our 30-day on the left and then our 1 year on the right. And so, again, zooming out from procedure day, which is so important, but really, how does the registry ensure that you're reflected as a true, robust structural program? Connecting data to decision-making, I want to give you 2 examples of how we were able to do that. The first is a documentation gap. It's, again, noticing those patterns before they become problems. I noticed a gap between some of our patients' comorbidities, their STS score, their frailty, and once we corrected that, we were actually able to improve the accuracy of our risk-adjusted outcomes. And I think a big takeaway is that most people don't realize that accurate documentation is the biggest flex that you have. It's a huge lever as far as ensuring that you have quality performance. So when you take into account their frailty, their comorbidities, maybe they're not being fully captured, or if you just kind of float through the KCCQ initially, well then it's going to look like you're caring for patients who really aren't that sick, and then when in reality you're caring for truly complex patients. We talked about setting expectations. How do those expectations line up with your KCCQ scores and quality of life? And, you don't want to, you want to just ensure that accuracy. That's something that I was able to pick up on being empowered in this role. The other thing is the uptick in 30-day readmissions. We had a lot of readmissions that were coming back, and our heart team wouldn't even really be notified. Of course, they're being admitted for something non-cardiac, but it's hitting our registry. And so that actually turned into a QI project where we were able to turn this into a system-wide. We engaged our EPIC folks, and now if a CT surgery or structural patient hits an ER, an urgent care, or a hospital admission in our system, it pops up a best practice alert instructing the ED or the admitting provider to contact the heart team. That's been huge for us. Not only for the registry, but for the purpose of patient care and ongoing, making sure that these patients, we have that accountability. So let's talk about how to put all that together. I think that there's a lot to be said about heart team alignment through data, and I want to emphasize heart team in this situation because I feel strongly that your outcomes don't need to be reported in a quality committee in the corner of the hospital. These outcomes need to be in front of your structural team, folks who have their hands on the device, who are there in the clinic, who are there on the procedure day. They are the ones who have the direct impact, and that's what leads to change and innovation. But also, I want to encourage you to set the expectation for participation amongst your team, not only for the purpose of quality improvement, but I think it's also a great way to highlight what's working well. And, you know, this is a mirror. It can be a spotlight as well, not just a scorecard. Gives you time to adjudicate outliers, the definition review, and a new update to the TVT is they've got the professional level dashboard, so your implanters can compare themselves to others in the hospital, the system, and then also nationwide. So we'll get into this a little more later on in the symposium with Misty talking about other efficiencies and tracking amongst your program. But I just want to highlight that quarterly outcome reports, what's beyond that? We have a star rating, publicly reported. This is the composite risk model. Totally separate from star ratings amongst STS, but so important, especially with the 3-year rolling data. Again, your work compounds, these quarterly metrics compound. What about referral and procedure volumes, tracking your programmatic metrics, timeline to therapy, hemodynamic data, ensuring that quality of life, you know, we really place an emphasis on flagging patients who fall outside of our defined treatment goal timeline, and also with hemodynamic data. We will flag patients if their gradient jumps in accordance with the VARC3 criteria. We're always looking at that. If their KCCQ falls off when they come back for their 1-year appointment, we want to look into that and ensure, again, zooming out from the procedure day and demonstrating that we are a robust structural program. These are some examples of how we report that data out on a quarterly basis. Very transparent, and I think that, again, it's a big highlight reel for us, but we're also constantly working to ensure that we maintain this high level of performance. So I do want to highlight that. That being said, you really can't improve what you don't measure, and then you're not going to improve what no one owns. And so having your heart team at the center of this discussion is paramount. And I think that the valve program coordinator is the one who definitely brings that intentional team-based coordination. So, of course, in reality, the talk is called Registry to Reality. So in a busy program, it's super easy to feel like quality is like somebody else's job, especially if you're not directly inputting that data. But I think that if you're empowered as a coordinator to be visible, engaged, and then connecting that data to the daily practice, that's really when the real change happens. I can connect the data that we look at really to the team's experience every day. And that's probably one of the most gratifying parts of my role is that I'm there when the referral comes in, contacting the patient, getting them ready for a valve clinic, educating them on their procedure, and then being able to translate this into nationally recognized data is so important. But data is powerful only when it's understood and acted on. So I would encourage you to review your registry, have a login to TVT, and then just ensuring that this becomes a highlight reel as well for your program. It definitely unified our team going through each quarter and highlighting this, but also showcasing our process that led to improvement. We noticed this, our team reviewed this, and our outcome improved. So again, valve program coordinator role is so powerful. You're bridging the clinical to the strategic. Hope this was helpful. Thank you so much, and I welcome any questions.
Wow. Well, as a testament to the hard work and fortitude that you put into it, I think you deserve like a 10-star rating, not a 3-star rating. I'm very jealous about the work that you put in. I think that you guys do a phenomenal job. And the point about the heart team and the data, I think that's something that can get really diluted in a large program. So I think this is a really important lesson for many of us to, really, really understand the data and inform the decisions that we're making. So thank you, Natalie.
I think a great point. So we are lucky to have a data sort of registry nurse but that person was like in a corner in a building that we never talked to. So we had to bring her in. Now that we had more time in our heart team meetings, she now comes to our meeting once a month. So everybody is aware of what we're doing. Everybody knows the numbers. So we had to bring her in to be very visible and very transparent that this is what we're doing. And you're right, we made changes because of that. And then the next month we looked at it. So it was very helpful to bring her in and so everybody is aware of what's happening on a day-to-day basis.
Yeah, Natalie, I've heard you talk about the registry, and I'm always in awe how much you make the registry work for your program. You know, there's nothing worse. We also have someone who inputs that data in and then brings it to us. But I didn't really realize until I was in this role of how important that data is for your program and how it looks on the outside. And so you can have the best operators in the world doing fantastic things, all of the research, coolest procedures. But if you don't have someone inputting the data or writing on your KCCQ that it wasn't completed because of a reason, or the 5-meter walk wasn't completed because the patient isn't ambulatory, your program doesn't look good. So really having insight into that is super important with all of these structural heart programs.
To piggyback off of that, patients now pay attention to that, right? So I'm in Boston. You can walk a block one way, every way, and you can go to another TAVR center, and they'll come in and say, how come your program only has 2 stars, but I can go next door and they have 4? And you have to be able to defend that, right? And you have to understand and be able to talk about that. So patients are really well informed with this data, which is, prompts, adds gas to the fire as to why you really need to be on top of it.
Thank you all.
All right. I think we're on to our last speaker, and then I think we're going to open up to some discussion within the group and the panel here. So Misty is going to bring us through moving the needle and turning the insights into impact for structural heart programs. So thank you for being here.
Thank you so much. And I feel like my talk really dovetails off of Natalie's, and it's ironic that both of us are VCCs and TVT registry site managers, which I feel like is kind of an anomaly these days. You don't see both, which I feel like we both should get a lot of wine after this too. So when we discuss advancing structural heart programs, conversations often center around new devices, technologies, advancements, but even the most innovative device may not yield the desired outcome if the processes behind it are not operationalized or optimized. So my focus today is really to talk you through how to drive meaningful change in your program. So we're going to dive down the QI rabbit hole a little bit, which is where I love to live. So hope you join me on that journey. So today's objective is to really highlight this 4-step process. This is inspired by lean methodology, implementation science, IHI's model for improvement, really focusing on defining the right problem. What do you need to focus on right now? And how do you engage the right team for that problem? How do you streamline workflows and then monitor and scale that for a larger impact? So first, I feel like it's important to mention and really focus on why this is important. As the picture at the top here depicts, behind each data point is a patient. As Natalie highlighted as well, we have a magnitude of data points available readily at our fingertips thanks to the registry, but there's not a lot of clear next steps of what do you do with this information. Data is often siloed, resources limited, and a lot of times resistance to change is a real thing. It can stall progress. So in order to break those barriers down, you have to have those conversations. And throughout this talk, I really ask all of you to think about what is a pain point that you have in your program. If you were to improve that, would it significantly impact your patient outcomes? And who at your facility can help to take ownership of that? How will you know in 6 months from now that what you've implemented has been beneficial? The first step of this is really to focus on defining the right problem. I mentioned going down the rabbit hole again, which is where I feel like I stay a lot of times, but if you don't know where the problem starts, how can you fix it? So starting at the TVT registry, again, is a good starting point. Look at a metric that is consistently below the 50th percentile or one that is consistently low performing. Do a deep dive into it. You can look at the patient level detail in the registry and see if you can extract any patterns. Or there are certain patients or certain cohorts that are consistently readmitted. Maybe your high-risk patients, elderly, frail. I mean, we we understand that, but being able to extract and pull those patterns out helps provide significant insight to really guide your next steps. And then map out your process. Also mentioned on here is operational metrics. So tracking your throughput. Do you know how long it takes a patient to get from referral to their treatment? If not, do you have a way to track that in your EMR? In Epic, we were able to incorporate the structural heart build, where we have a dashboard now to view that on a regular basis. But a good old spreadsheet could be beneficial as well if you don't have that EMR capability. But really look at those items and map out the process. So what exactly happens from the time a patient is referred to the time they are treated? When you visualize this, a lot of times you can see those bottlenecks or redundancies, or maybe some of these inefficiencies are due to inconsistent communication, manual processes, and what exactly can be done to improve that. So then you look at your root cause. Why is this happening? Doing a fishbone diagram, or really, again, diving to the deeper root of it, really can help guide your next steps. And as you do this, you're likely going to uncover multiple opportunities. It could be really enticing to try to tackle 5 different projects at one time, but that's not feasible, and likely you will end up with the unintended outcomes. So really using a prioritization matrix or categorizing your items based on effort and impact, what is feasible to be able to implement in your program based on your available resources. Next is really about aligning the right team. So if you are focusing on readmissions, your team is likely going to include your implanting physicians, coordinators, discharge educators, case management. But if you are focusing on improving vascular complications, that team is likely going to look different. So making sure that your team is aligned with your identified problem is really key here. And the unfortunate part is about 70% of change initiatives are not successful because they are not fully rolled out efficiently and they don't have those key stakeholders involved. So I always like to think about 3 different levels of individuals to be involved in a team. You have those frontline workers, the ones that are actually doing the work related to the problem you're looking at. You have those who can support it, your management, the physicians. Then you have those who can resource it, leadership. When you're really tackling a big initiative, having a kickoff meeting can be really beneficial when you bring all those key stakeholders together and you can really discuss and share the why. Why is this important? Why do we need to be on board with this? And then for everyone to understand what's in it for me. That is how you help to build that buy-in and support. Even doing an accountability tracker so everyone that's involved in the process knows exactly what their expectations are and what the goal date for completion is to also reconvene. As you're doing this, it's important to mention that change is hard. It's uncomfortable, it's disruptive, people don't like it. And when you're forming a team, there's various stages. You have the forming stage, like the kickoff meeting, where everyone's really excited, coming together. Then you have the storming phase, where it is hitting everyone like a ton of bricks that their processes are about to change and it's uncomfortable. The norming phase, where everyone's coming back together and really sharing that common goal again. And then the performing, where you're working as a well-oiled machine. So knowing exactly where your team is in that process is really key to be able to help guide and lead it. Now, on to my favorite part, the optimization and streamlining. One great way to do this is a simple affinity diagram or get your sticky notes out, okay? So when you, let's say you're focusing on readmissions and you have those key stakeholders together and you're trying to figure out how can we make this better, calling out various ideas, writing them down, categorizing them to see what is the greatest cluster surrounding. Is it patient education? Is it documentation? Is it procedural complications that are causing patients to be readmitted? So being able to see where your primary focus needs to be helps guide the next steps here. Again, I'm bringing up a prioritization matrix because I think they're great to help organize multiple ideas that you have, and it really helps to organize based on how much effort it is going to require you to implement and how much impact is it going to have on your facility. So this these are just various ideas, but when you're considering optimizing for today, those are the quick wins that you can implement, such as implementing a checklist, or even, as Courtney had mentioned, the little pink sticker. That is an easy item that you can implement that can have a great impact on your program. Long term, whenever you are considering sustainability, that is when you want to see, are we biting off more than we can chew for long term? Is this going to cause a lot more work for our frontline staff? And is this going to be more burdensome and not maybe produce the result that we want? So when you're considering the sustainability, really trying to see how can you embed these processes into your EMR, make it a part of your daily workflows, that will give you a lot more success later on as far as trying to sustain your initiative. And let's say you have your idea formed. Do you want to roll that out to all of your patients or across your program without knowing if it's actually going to work and be beneficial? So really making sure that you are piloting it. Maybe you are doing that new discharge process and you're going to do it maybe for those high-risk patients initially to focus on. Monitor that closely. Is it producing the results that you're anticipating? The PDSA, or Plan, Do, Study, Act, is essentially the process that I've walked through so far, but it just really enforces the importance of looking at the data, refining processes, and having that continual communication so you can expand this for more patients and to give you that sustainability. Now, alongside with sustainability, approximately 30% of change initiatives do not sustain after 1 year. And a lot of that is because you have a lack of visibility. And so I've mentioned dashboards that we use in our EMR. TVT Registry has dashboards readily available. They look great. But if you're not sharing that throughout the team, it is just staying siloed. So the reason I have a picture of a Pink Floyd emblem here is because that is what we call our quarterly multidisciplinary meeting. Pink Floyd intrigues you, right? So at that meeting, we have a representative from each department that is involved in the care of our patients. We use that as a forum to be able to review the STS, TVT metrics, PI projects we're working on, outcomes of projects that we've worked on, future directions that we want to go on, going deep into our star ratings so everyone has understanding. But we also take that time to listen. So we have administration there as well. So if it's uncovered that there's a resource that we need, then we can revisit that at a later meeting. But leadership is present, frontline is present. So making sure that you're integrating this on a daily basis. We also carve out at least 5 minutes each month to be able to review the TVT metrics, make it a part of the standing agenda, because when you discuss it on a daily basis, it doesn't become some rainbow that is somewhere out in left field. It is a part of your daily operations. So these are just a couple of examples of what we have achieved and really been able to attain at our facility. In 2019, we went through the transcatheter valve certification, which essentially lit a fire regarding doing a root cause analysis and understanding why processes and outcomes were happening. And vascular complications were one of the first items that we tackled through a stepwise approach, which I think is really important as well, to implement one item at a time, monitor it. Are you getting the results that you're anticipating before you roll out the next item? And then readmissions, that has been something that we really have focused on. And the primary commonality was a lack of education. So just streamlining that process for patients, doing structured follow-up with them afterwards, really helped to give the patients a better overall experience. And then our throughput, making sure that we could treat patients in a more timely manner. So from the time we receive a referral to the time the patient receives their intervention, looking to see what bottlenecks were present. Were there redundant tests that maybe weren't needed? We were able to add additional procedure days, streamline the follow-up and evaluations. But a large driving force that I want to mention as well is our physicians. Our implanting physicians that we have, their passion, dedication, and true love for what they do is translated throughout the team. And it is something that we are so grateful for. One of my ICs is in the audience. I'm not going to call you out, but thank you for being here. You make such a difference. So thank you for what you do. But having someone who is able to help drive this process with you, and you're not doing this completely by yourself, is an extremely important point. So, not to get emotional. Now, where do you start on Monday? Okay, I asked you all to think about a pain point to tackle at your program. Is there any low-hanging fruit or an item that you can implement that would be essentially a quick win for you? How can you continue to scale that out to improve outcomes? And it's important to remember that continuous improvement is a journey, and behind every data point is a patient. And that's really ultimately why we're all here. So thank you.
I think you gave us a huge, great roadmap to follow, and I think that you're really fostering team collaboration within your program. So thank you for sharing that message. I know that we're really close on time, so I would welcome any comments that the panel has on Misty's wonderful talk, and really want to, pool the audience and see if there's any questions that anybody wants answered. So thank you again for attending.
I just wanted to briefly chime in and say you made the IHI very proud. They're going to want to scoop you up after that presentation. You did a great job. But, I think QI is so daunting for a lot of people, right? It's something hard to approach. And so I would encourage anyone who's interested in kind of doing what you both are doing up here is look for a preceptor within your hospital, because they don't even need to be in your department. They don't even need to be in cardiology. As long as they understand the QI steps, they can help guide you. And really having that mentorship up front can make a huge difference for you, and it's going to help your impact.
Any questions in the audience at all? No? Yes, no? Okay, well, we really appreciate everybody's attendance, and again, we look forward to convening again next year for this annual meeting. So everybody enjoy their evening. Thank you.